Thank you for joining us today on the Anesthesia and Perioperative Medicine channel. This is Rebecca Jane Collins. Today, we are diving deep into one of the most high-stakes scenarios we face in the operating room, managing the airway of a patient with significant tracheal stenosis. This is one of those situations that really puts our training to the test. A solid, well-thought-out plan is literally the only thing standing between a smooth anesthetic and a complete, irreversible catastrophe.
So here's how we're going to break it all down today. First, we'll start with a real-world, complex case that's going to be the foundation for everything we discuss. Then we'll get into the nitty-gritty of reading a CT scan, not just as a radiologist would, but as an anesthesiologist hunting for danger signs. From there, we'll build out our airway strategy, covering our safest options. After that, we'll tackle the often underestimated challenges of ventilation and, of course, extubation. And finally, we'll zoom out to look at the big picture, the anesthetic management for the definitive surgical fix, a tracheal resection.
All right, let's get right into it. There's no better way to understand the stakes than to walk through a real case. This is where the rubber meets the road, where a critically compromised airway collides with a massive, high-risk surgery. So meet our patient. He's diagnosed with hepatocellular carcinoma that has already metastasized. The surgical plan is, well, it's huge. It's a multidisciplinary affair involving a hepatic segmentectomy, a hemicolectomy, a right nephrectomy, and a lymph node dissection. So right off the bat, we're thinking long surgery, major fluid shifts, and a high risk of bleeding. But here's the kicker, the one line in the chart that makes every anesthesiologist's pulse quicken. A note from a general anesthetic 40 years ago mentioning suspected tracheomalacia. That single, old piece of information is a massive red flag that changes our entire approach.
The preoperative chest CT confirmed our fears and then some. Just take a look at this axial view. What we have here is a severe subglottic tracheal stenosis. And you can see, the lumen isn't even circular anymore. It's been compressed into this ominous crescent shape. At its absolute narrowest point, it measures just 7 millimeters by 15 millimeters. This isn't just a slight narrowing. This is a critical anatomical choke point right below the vocal cords.
So this brings us to our first huge decision point. We're looking at a 7 millimeter opening. Now, a standard endotracheal tube for an adult male might be a 7.5 or an 8.0, and remember, that's the internal diameter. The external diameter is even bigger, over 10 millimeters. So is a routine intubation after induction even remotely safe? The answer is a hard no. Trying to force a tube through that opening could cause mucosal trauma, bleeding, and swelling. You could very easily turn a very narrow but patent airway into a completely obstructed one. A routine induction is absolutely off the table.
With the CT evidence staring them in the face, the team made the only truly safe decision. The plan was set, an awake fiber optic intubation. This whole strategy is built on the most sacred rule of difficult airway management. You maintain spontaneous ventilation, you keep the patient breathing on their own until that endotracheal tube is safely past the obstruction and you have a beautiful continuous end-tidal CO2 waveform on your monitor. Only then can you breathe a sigh of relief.
That CT scan was our crystal ball. It gave us a critical warning. So let's lean into that. How do we systematically break down these images to predict, and more importantly, prevent an airway disaster before we even bring the patient into the room?
This is a question that causes a lot of anxiety, and for good reason. Does giving a muscle relaxant directly cause the tracheal cartilage to just pancake? Well, it's a bit more nuanced than that. The drug itself doesn't dissolve the cartilage. But in tracheomalacia, that cartilage is already weak and floppy. The patient's own respiratory muscles are actively splinting that airway open. The moment you administer a muscle relaxant, you take away that natural muscular scaffolding. Then you add positive pressure ventilation, and suddenly you can have a dynamic collapse. So the risk isn't just the drug, it's the total loss of airway tone combined with positive pressure.
And that risk of collapse brings us to the ultimate nightmare scenario we all train for, the cannot intubate, cannot ventilate situation. It's usually not one single thing, but a perfect storm created by three converging problems. First, you have some kind of underlying obstruction that gets exponentially worse once you take away muscle tone. Second, you have a hard stop, a physical barrier, like our patient's stenosis, that you simply cannot pass a tube through. And third, to top it all off, the patient might be difficult to mask ventilate to begin with. When those three things happen at once, you are in a true emergency, heading straight down the difficult airway algorithm towards a cricothyrotomy.
To stay far away from that nightmare, your CT review has to be a focused investigation. You need to answer 4 key questions every single time. 1. What is the absolute narrowest diameter? That tells you what size tube might fit. 2.
How long is this narrowed segment? Is it a thin web-like stenosis, or is it a long, tortuous tunnel? 3. Where is it? How much room do I have to work with between the vocal cords and the carina? And number 4, what does the tracheal wall itself look like? Is it nice and round, or is it C-shaped and floppy, screaming tracheomalacia?
Let's put some hard numbers on these danger signs because they really matter. If that minimal diameter is 6 millimeters or less, that's a major red flag. Your chances of passing even a small adult tube are slim. Now, if you see a diameter of 4 millimeters or less, you need to stop. That's a phone call to your thoracic surgery or ENT colleagues to discuss having them on standby with a rigid bronchoscope or even discussing an elective tracheostomy or ECMO. A stenotic segment longer than 2 centimeters is also a bad sign. It's going to be a tough journey with the scope, and you can expect high ventilation pressures. And of course, that crescent shape, a sign of tracheomalacia, means you have to assume the airway will try to collapse the second the patient stops breathing on their own.
Okay, so we've done our homework. We've analyzed the CT, we've identified the dangers. Now let's talk about the game plan. How do we actually safely secure this airway? This is where all that planning gets put into action.
When you're faced with a seriously narrowed airway, there are really only 3 primary, safety-first strategies on the table. First, and arguably the gold standard, is the awake fiber optic intubation, just like in our case. The second option is a very careful, very controlled inhalational induction, titrating your sevoflurane to maintain spontaneous breathing while you instrument the airway. It's elegant, but it's technically demanding. The third option, which is often our ultimate backup plan, is having a surgeon secure the airway with a rigid bronchoscope. That metal scope can act as a stent to open up a collapsing airway and allow for ventilation. But notice the common theme here. All 3 strategies are built around one core principle. Do not paralyze the patient until you are 100% certain you have a secured, confirmed airway. This algorithm is a fantastic way to standardize our thinking. Let's just walk through it. The decision tree branches based on that critical measurement, the minimal tracheal diameter. If you're lucky enough to have an airway wider than 8 millimeters with no other red flags, a standard IV induction is considered a reasonable option. But once you get into that 5 to 8 millimeter zone, the yellow zone, that's exactly where our patient fell. The recommendation here shifts to a more controlled approach, like an anesthetized fiber optic intubation after a gentle gas induction. And then you have the red zone, anything less than 5 millimeters. Here, the algorithm is firm. Your primary plan should be an awake fiber optic intubation. You can see how the team in our case, with a 7 millimeter airway, made the very prudent decision to treat it as if it were in the red zone. That's smart, conservative anesthesiology. Now, to pull off a smooth, awake intubation, you can't just hope for the best. You need to be an expert in the neuroanatomy of the airway. It's about methodically numbing 4 distinct sensory zones. First, the nasal passage, where you're targeting the sphenopalatine ganglion to make the scope's entry comfortable. Second, the oropharynx. Here, the main event is blocking the glossopharyngeal nerve, cranial nerve 9, to get rid of that powerful gag reflex. Third, the laryngeal zone, from the epiglottis down to the cords, which is all about blocking the superior laryngeal nerve to prevent coughing. And finally, the tracheal zone, below the cords, where you need to block the recurrent laryngeal nerve's territory to allow the patient to tolerate the tube itself. So, how do we actually do this in practice? It's a combination of topical anesthesia and specific nerve blocks. Topicalization can be broad, like with nebulized lidocaine, which is great for covering a large area. Or it can be more targeted. My personal favorite is the spray-as-you-go or say-go technique, where you inject lidocaine through the working channel of the bronchoscope right before you advance. It's incredibly precise. Then you combine this with specific nerve blocks. The glossopharyngeal block, done intraorally at the base of the tonsillar pillar. The bilateral superior laryngeal nerve block, done externally by walking off the hyoid bone. And the transtracheal block, where you inject lidocaine right through the cricothyroid membrane to numb the trachea from the inside out. When you put it all together, the patient can be remarkably comfortable. Okay, deep breath. The tube is in, it's past the stenosis, the cuff is up, and we're getting end-tidal CO2. We can relax for about 30 seconds because our job is far from over. Now we have to manage ventilation through what is likely a smaller than ideal tube for a very long surgery, and then plan for a safe extubation. These are their own unique challenges. Here's a super common scenario. You had to place a size 6.0 tube, and an hour into the case, the ventilator starts alarming with the high peak inspiratory pressure, or PIP. The first question you have to ask is that high pressure just a reflection of the ventilator trying to push gas through a narrow tube, like blowing through a coffee stirrer? Or is it because the lungs themselves have become stiff and non-compliant? The key to telling these two apart is the plateau pressure. If your PIP is sky high but your plateau pressure is normal, the problem is high resistance, most likely from that small tube. But if both your PIP and your plateau pressure are high, that's a much more worrying sign. That points to a problem with the lungs themselves, something like pulmonary edema or ARDS.
So how do you figure out that all-important plateau pressure right there at the bedside? It's incredibly simple, yet so powerful. You just use the inspiratory hold button on your ventilator. You press it, and for a second or two, it pauses all airflow at the peak of inspiration. This allows the pressure in the entire system to equalize from the machine all the way down to the alveoli. The pressure it holds at is your plateau pressure. It's a direct, real-time measurement of the static compliance of your patient's lungs. It's one of the most useful buttons on the whole machine.
So now, fast forward. We're many hours into the surgery. There have been fluid shifts, maybe some inflammation, and we're approaching that final high-risk moment, extubation. What is the single most important principle we need to follow to make sure we don't snatch the flute from the jaws of victory and lose the airway right at the finish line?
The safest extubation isn't a single action. It's a staged, deliberate process. It always starts with an assessment for airway edema, usually with a cuff leak test. But the single most valuable technique in our toolbox for a high-risk extubation is the use of an airway exchange catheter, or AEC. You thread it through the endotracheal tube before you pull the tube out. The AEC then stays in the trachea, acting as a lifeline. If the patient starts to struggle or develop stridor, you can insufflate oxygen through it. But more importantly, it acts as a guide wire, allowing you to rapidly and blindly railroad a new endotracheal tube back into the trachea without having to re-instrument the airway. It's your ultimate safety net.
All right, for our final section, let's zoom out and talk about the definitive fix for many of these patients, the tracheal resection and anastomosis. This surgery comes with its own completely unique set of anesthetic challenges, the biggest one being that for a period of time, the airway is literally open to the surgical field.
Okay, managing ventilation when the surgeon has transected the trachea is the central challenge of this anesthetic. Let's compare the main options. The traditional workhorse is cross-field ventilation. The surgeon places a sterile, armored tube into the distal trachea, passes the end over to us, and we connect our circuit. The big advantage is that we have complete control of ventilation. The downside is that it's another piece of equipment in a crowded surgical field. A more recent technique is to keep the patient spontaneously breathing through the whole case. This is fantastic for enhanced recovery protocols, but it's a real high-wire act that requires a very deep regional block and an incredibly experienced team. Finally, there's jet ventilation. A small catheter delivers high-pressure pulses of oxygen, which gives the surgeon a totally unobstructed view. But it comes with very real risks of barotrauma, stacking breaths, and inadequate CO2 removal. There's no single right answer. The choice depends on the patient, the surgeon's preference, and a whole lot of communication.
And that really brings us to our final, thought-provoking question. We are living in an incredible time for anesthesia. Techniques like non-intubated thoracic surgery, advanced regional blocks, and new ventilation modes are pushing the boundaries of what we can do. It's truly exciting. But as we embrace all this innovation, the question we must constantly ask ourselves is this: how do we balance these amazing new techniques with the timeless, fundamental principles of airway safety? Because at the end of the day, no matter how fancy the technology gets, our core mission never changes: to have a plan A, a plan B, and a plan C, and to always protect the patient's airway.